Hello, and thank you for being here. If you had a sleeve gastrectomy and the weight is coming back, this video is for you. Not to scare you or to judge you, but to explain exactly what is happening inside your body and what you can do about it. The sleeve gastrectomy is the most commonly performed bariatric surgery in the world. It works, and it works beautifully for the great majority of patients, but it's not a permanent cure for a permanent disease. Obesity is chronic and relapsing. And just like blood pressure medications sometimes need to be adjusted, sometimes the results of a sleeve gastrectomy need to be addressed. A multicenter study of 830 sleeve patients followed for nearly 10 years found that maximum weight loss peaked at 24 months. After that, 64% experienced weight regain of more than 10% from their lowest weight. Nearly 58% regained more than 20%, and over 10% finally needed revisional surgery. A separate study of 339 patients with at least 5-year follow-up found that only 20% maintained appropriate weight loss beyond that mark. And a systematic review found that rates of regain range from 5.7% at 2 years to 75.6% at 6 years, depending on the definition used. These numbers are not meant to discourage anyone. They're meant to prepare you, because weight regain after sleeve gastrectomy happens through two distinct pathways, mechanical and metabolic. And the treatment depends entirely on which pathway is driving your regain. Today, I'm going to break down both pathways, explain how we tell them apart, walk through every treatment option, and show you how to protect your results going onward. The first pathway is mechanical. It's about anatomy. After sleeve gastrectomy, your stomach is a narrow tube that holds about 3 to 4 ounces. We remove roughly 75 to 85% of the stomach, including the fundus, which is the main factory for the hunger hormone ghrelin. What remains is a banana-shaped sleeve designed to limit how much you can eat at one time. But over time, that sleeve can stretch. In a prospective study using 3D CT imagery, found that 61% of sleeve patients experienced measurable sleeve dilation within the first year after surgery. The gastric tube itself was responsible for 91% of the volume increase. A separate study found that patients with residual gastric volume above 180 milliliters had significantly lower excess weight loss than those below that threshold, 32% versus 52%. And a third prospective study confirmed that the amount of weight regain correlated directly with the residual gastric volume on CT scan. What does this mean in practical terms? As the sleeve stretches, you can eat larger portions without feeling full. The restriction that made the surgery work in the first place gradually fades. You're not eating more because you lack discipline. You're eating more because the anatomy changed. Now, I want to be clear about something. A 2025 study using a mouse model and a single-cell RNA sequencing of human tissue found that post-sleeve gastric dilation may reflect adaptive stem cell-driven regeneration and did not correlate with weight regain or increased ghrelin secretion in the animal model. So dilation doesn't automatically mean failure, but when dilation is combined with metabolic changes I'm about to describe, the effect compounds. The signs of mechanical regain are straightforward. You can eat larger portions than you could a year or two ago. You don't feel as full quickly. You can eat a full plate without discomfort. An upper GI study or 3D CT scan can confirm the increased sleeve volume. The second pathway is metabolic. It's about hormones, metabolism, and the environment you live in. When you had your sleeve, something remarkable happened. Ghrelin dropped dramatically because we removed the fundus. GLP-1 and PYY, the satiety hormones, surged. Your brain stopped screaming for food. A meta-analysis of 28 studies and 653 patients confirmed these changes. After sleeve gastrectomy, fasting ghrelin dropped significantly, while postprandial GLP-1 and PYY both increased. But here's what happens over time. Your body adapts, ghrelin levels begin to rebound, leptin resistance can return, your resting metabolic rate slows through a process called metabolic adaptation. The hormonal advantage that surgery gave you starts to erode. A narrative review confirmed that weight regain affecting 20 to 30% of patients is influenced by these hormonal adaptations, combined with metabolic adaptation leading to reduced resting energy expenditure. And it's not just that your hormones are fighting you. The modern food environment is fighting you too. Ultra-processed foods now make up for over 50% of total daily calories in many countries. A Lancet series confirmed that the ultra-processed dietary pattern is a key driver in the global obesity epidemic. A landmark randomized controlled trial showed that people eating ultra-processed diets consumed 508 more calories per day than those eating unprocessed diets, even when the meals were matched for total available calories and macronutrients. And here's the data point that connects this directly to bariatric patients. A longitudinal study found that the contribution of ultra-processed foods to caloric intake gradually increased after 3 months post-surgery, and by 60 months, the dietary intake profile approached that of pre-surgery period. A cross-sectional study of 93 bariatric patients found that calories from processed foods were significantly higher in the weight recurrence group. So your hormones are pushing you to eat more, and the food environment is engineered to make you eat more. This is not a willpower problem. This is a biologic and environmental assault on a system that already was vulnerable. The signs of metabolic regain are different from the mechanical regain. Your hunger has returned even though your portions are still small. Your cravings, you have cravings that you didn't have before. You're eating the same amounts but regaining weight. Your energy is lower and your resting metabolic rate has slowed. Most patients who regain weight have elements of both pathways, some mechanical dilation and some hormonal rebound, compounded by behavioral factors and the constant pressure of an obesogenic food environment. That's why the workup matters. Before we decide on any treatment, we need to understand what is driving your specific regain. The evaluation includes a detailed history of your weight trajectory, your hormone patterns, your diet, and your exercise habits. An upper endoscopy to directly visualize the sleeve, measure its size, and rule out other problems. An upper GI contrast study or 3D CT scan to precisely measure sleeve volume. Laboratory studies including metabolic panels, A1C, lipid panel, vitamin levels, and thyroid function. We also do a nutritional and psychological evaluation because emotional eating, binge eating, and depression are all independently associated with regain. A systematic review of 32 studies covering over 13,000 bariatric patients found that risk factors for regain fell into 5 categories: anatomic, genetic, dietary, psychiatric, and temporal. Anxiety, emotional eating, binge eating, and sweet consumption were all positively associated with regain. But so were factors completely outside your control, like gastric volume, genetics, and time since surgery. The goal of the workup is to answer 3 questions. What's the anatomy? What's the physiology? And what's the behavior? Only when we understand all 3 can we choose the right treatment. For metabolic regain, GLP-1 receptor agonists have changed the game. A systemic review and meta-analysis of 19 studies found that GLP-1 medications produce mean weight reductions of approximately 7 kilograms with liraglutide and significantly greater weight loss with semaglutide, with a mean difference of over 4 kilograms between the two. A separate meta-analysis found that tirzepatide produced the greatest weight reduction at 12.6 kilograms. A retrospective study of 50 patients found that GLP-1 receptor agonists reversed approximately 2/3 of the post-bariatric weight regain. But medications are not the only tool. A dietary reset focused on whole, unprocessed foods and a minimum of 60 grams of protein per day can restore the nutritional foundation. Behavioral support, whether counseling, support groups, structured programs, addresses the psychological barriers that no medication or surgery can fix. For mechanical regain, revisional surgery can restore restriction and reignite the metabolic advantage. A 2026 ASMBS statement confirmed that revisional surgical options, endoscopic therapies, and obesity-modifying medications all play important roles, with management requiring individualized, multidisciplinary assessment. A network meta-analysis of 23 studies found that SADI-S ranked highest for both excess weight loss and total weight loss among revisional procedures after sleeve, with comparable complication rates as other options. Conversion to gastric bypass, anastomosis gastric bypass are also proven options. A 2026 comparative study of 195 patients found that conversion surgery produced significantly greater long-term weight loss than medications alone, with OAGB demonstrating the highest proportion of patients achieving clinically meaningful weight loss. A 2026 propensity matched study of 220 patients found that endoscopic revision of the sleeve produced similar weight loss to surgical revision at 12 months, approximately 10 to 13% total weight loss, with significantly better safety profile. 0 serious adverse events in the endoscopic group compared to 11% in the surgical group. Regardless of which pathway is driving your regain, there's one strategy that applies to everyone. Protect your body composition. Not just the number on the scale, your muscle, your fat-free mass, your metabolism. A controlled clinical trial found that patients who combined resistance training with protein supplementation gained 1.5 kilograms of fat-free mass and nearly 1 kilogram of skeletal muscle mass, while the control group lost mass. A meta-analysis of 33 studies confirmed that combined aerobic and resistance training produced the greatest preservation of fat-free mass, with exercisers losing only 17% of total weight as fat-free mass as compared to 24% in non-exercisers. The patients who protect their muscle protect their metabolism, and the patients who protect their metabolism are the ones that maintain their results. I want to close with the single most important finding from the 10-year data. In a multicenter study of 830 sleeve patients, the strongest predictor of lower weight regain was not diet, it was not exercise, and it was not the size of the sleeve, it was adherence to follow-up. Patients who attended 5 or more postoperative visits had significantly less regain than those who did not. That tells you everything you need to know. The patients who stay connected do better, not because they're stronger, but because they have support. If you're regaining weight after sleeve gastrectomy, the next step is not shame, it's not a crash diet, it's a conversation with your surgeon, with your dietitian, and with your team. We'll do the workup, we'll find the cause, and we'll build a plan together that helps you find the best chance of long-term success. You took the hardest step when you had your surgery. This next step is just the next chapter. I'll see you in the next video where we're going to talk about weight regain after gastric bypass and what really is happening and how it differs from the sleeve. Thank you for watching. Real science, real surgery, real results.